Hello everyone, and welcome to the webinar this afternoon. It's great to have you with us. So just to let you know, for those of you who don't know me, I'm Anna and I'm the Head of Support Services at Overcome. And please do get in touch with us. It will be me or my colleague Laura or Annie or Catherine who pick up any messages or answer the phone with you. So if you want to talk anything through or need any information, please do get in touch with us Monday to Friday, 10 a.m. to 5 p.m. And we're available through the support line, email, text message, instant chat through the website. We can set up a Zoom one-to-one with you. Essentially, we try and have any channel available that would be your preference. We have that available to get in touch with us. So please do. And anything that you want to discuss after this webinar or any questions that occur to you later, please do get in touch with us. So today's webinar is something that has come up in many of our support group discussions, and you can see the various support groups that we have running on our website, and please do sign up and come along. And I'm just really pleased that Sarah, Dr. Batty, has been able to give us some of her time today to discuss this topic, because I think it's something that, as I say, we've been asked about a lot, and there's a lot of fear and uncertainty around it. So I'm delighted to welcome Dr. Sarah Batty, the specialty doctor of palliative medicine from the North London Hospice, to talk us through end-of-life care and what to expect.
Great, thank you. Well, thank you for having me. This is a topic that's very close to my heart. So I'm a specialty doctor at North London Hospice. I work in palliative medicine full-time, but I'm also a GP. Today I'm in GP land, as you can see from my background. So end-of-life care, what to expect. So I'm going to talk a little bit about my job and when we get involved in what we do. And yeah, if you have any questions, please feel free to hit me with them. So what is palliative care? So palliative care is the care of people who have been diagnosed with a condition that cannot be cured. So typically the bulk of our patients are often cancer sufferers, but we also look after people with dementia, heart failure, renal failure, and neurological conditions such as motor neuron disease, muscular dystrophy, a whole host of conditions where there is a limited life expectancy and modern medicine cannot find a cure. So in terms of what we do, our work is sort of split into two areas. So area one is managing symptoms in our patient population, and area two is looking after people at the end of life. So the bulk of our work, the bulk of my work, is actually managing symptoms in people with incurable conditions. And a smaller amount of my work is looking after people at the end of life. And I think it's a common misconception that hospice doctors or palliative care doctors just look after the dying. That's not true. We help people with a terminal illness or incurable condition to live for as long as possible and enjoy life for as long as possible, is a way that I prefer to phrase what we do. So in terms of symptoms that we get involved in, pain is probably the most common one that we tend to step in and help out with. And breathing difficulties is one of our specialist symptoms. Dry mouth, constipation is one of our favourite topics. Nausea and vomiting, anxiety and agitation, sometimes at the end of life, or low mood, things like that we can help with. Skin issues are sometimes a problem, and we can help there. Dry mouth, I've said twice. And carer distress, so often family members. So I say to our patients that we're here for them, but actually this time is actually incredibly difficult for people who love them and their support network, as they feel quite helpless and in terms of what they can do to support. So we're here to look after them as well. And then, as I said, end-of-life care is a smaller part of our work and what we do, but that is looking after people in the final weeks and days of life. And some people choose to be cared for at home, some people choose to come into a hospice, and some people are in hospital at the end of their life. So part of my job is to support people at the end of life in whatever environment they want to be in. And I work as a community palliative care doctor as well as an inpatient hospice doctor. So as I just alluded to, we work in various settings. So you've got the community team. I work with a team of nurses at North London Hospice, and we go out and see people at home. Some people, well, a lot of people just want to be at home as much as possible and avoid hospital admissions. And so we do our best to facilitate that. And also some people want to be at home for their final days of their life. That's important to them. And particularly during COVID, people haven't been wanting to come into the hospice as much, because unfortunately, as hospitals have, we've had issues with our visiting access. So we've probably supported a lot more people to die at home and kept people out of hospitals as much as possible because of the risk of COVID infection and the implications of that to our population. As I say, we work in a we do our work in a hospice setting as well, which is probably what palliative care is most famous for. About 70% of the patients who come into the hospice come in for symptom control, and about 30% come in to spend their final days with us. So again, even in the hospice setting, the majority of our work is looking after people who've got an incurable condition with their symptoms. We also have a hospital-based team. So if you go into hospital at any stage in your illness and you've got tricky symptoms at a stage of illness that can't be cured, then the palliative care team in a hospital can be referred to, and they can assess our patients in hospital. We have a close working relationship with various specialties. So for our cancer patients, we closely work alongside the oncology team. For neurological conditions like motor neuron disease and MS, multiple sclerosis, we work alongside neurologists. For our dementia sufferers, we work alongside the care of the elderly. And we also work alongside GPs, who are the cornerstone of all of our patients' care, really, because they are the centre point for prescribing and often have had the longest relationship with our patients. So we work closely with them. So when do we get involved as palliative care doctors and nurses? So as early as possible, really, in somebody's illness, if they have been diagnosed with a condition that can't be cured. We like to get to know patients well in advance of the dying phase of life so that we can manage symptoms when they start. So often at the time of diagnosis, in some patients, if they've got a metastatic cancer that can't be cured, an oncologist will refer to us so that we can walk alongside them in their treatment by the oncologist, and we can help manage symptoms. Whilst the oncologist is better at managing the actual disease and controlling that, we can help with any symptoms that the disease is giving. The symptoms that I mentioned before, so again, pain, breathlessness, distress, carer distress, constipation, things like that. So a referral can come from the oncology team or the specialist team who's diagnosed that incurable condition, or it can come via the GP. And we also accept self-referrals from patients and families as well. We have a form on our website, and I think most palliative care teams do that as well. So the end of life is what I've been asked to talk more about today. And that's a topic I think that fills most British people with horror, and we don't talk about death enough, I don't think, even though it's something that happens to us all. And actually, if we can talk about it more and normalise it more, it becomes less fearful. So what makes a good death? What are we striving to achieve in our work? So this definition by the London End of Life Clinical Network is pretty nice. So a good death is the best death that can be achieved in the context of the individual's clinical diagnosis and symptoms, as well as the specific social, cultural, and spiritual circumstances, taking into consideration patient and carer wishes and professional expertise. So really, it's a really individual thing, and part of my job is to work out with each person and their family what matters to them and what's important to them. So what environment do they want to be in, what are their spiritual needs at that time of their life, and how we can support the people who love them, who they want to have there at the time of their death, and trying to help that happen. So there's no sort of one size fits all. It's almost a bit like a birth plan, although I like to think that our plans tend to go better than some birth plans. Because we start early and we try and involve our patients and change our plan as things evolve and change, to ensure that people are peaceful and have an end of life that is dignified and what they wanted it to be. So as I say, we start conversations early. So the first time I go and see a patient at home after they've been referred to me, I'll put feelers out in terms of have they thought about end of life? Have they thought about where they would want to be at the end of their life? And some people look at me in complete horror and say, no, I haven't. But a lot of people actually look at me and they have thought about it and they do have opinions about where they want to be. And unless I have these conversations, I don't know what to do for my patients, and I need to have that information so I can advocate for them if they're not able to advocate for themselves. And similarly, family members need to know what their loved one wants so that they can advocate for them should they become more unwell. So as hard as these conversations might feel, they're really necessary. So what I want to figure out is what does my patient want and what do their family want? And at any assessment that I do, I always try and make sure that family are there. So anybody who wants to be involved in the discussions or understand better what we do to make sure that it's not just me and a patient. It is about the family as much as it is about the patient. And then we do some advanced care planning, which we've talked about and touched on already. So important questions that I need to know so that I can act in the best interest of the patients are questions like, well, if you were to deteriorate at this stage of your illness, would you want to go back to hospital for further treatment? Or are you at a stage in your illness? Oh no, I've lost my screen. Just bear with me a moment, so I'll get that back up. There we go. Or are you at a stage in your illness where you wouldn't want to go back to hospital and actually what you want to focus on is the best care I can give you at home? Alternatively, if you don't want to go into hospital, would you consider going into a hospice for symptom management? So there's some of the conversations that I have, and it's amazing how many patients don't want to go back to hospital, and actually that question's never been asked of them before. I think as doctors sometimes we put our patients or sort of as a country, I guess, we put patients on a conveyor belt where they go in and out of hospital, and we never really say to our patients, hang on a second, do you want to actually go into hospital? Is this just something that our healthcare system does as part of our routine? So often that's quite a pleasing question for some patients because they don't want to go back into hospital, and some of them don't want to have any further treatment, and that they're feeling ghastly with whatever treatment they're having, be it chemotherapy or the various diuretic treatment we use in heart failure patients. And actually what they want to do is focus on feeling as well as possible at home instead of having these treatments that are causing side effects. So the other question then is, well, if you want to stay at home, do you want us to try reversing any condition that might present itself? So for example, if you were to develop a pneumonia, would you want me to try and treat that with antibiotics, or would you prefer just to manage symptoms, knowing that that decision might shorten your life? And that's a bit of a mixed response. Some people feel very strongly that they would want antibiotics to try and lengthen whatever life they might have left. But some people feel that the quality of life isn't sufficient to want any prolonging of life. And actually that wouldn't be what they want. So we're trying to have an open dialogue with our patients about what they want, to empower them to be the boss in all of this. And without asking these questions, I just don't know how to help them. So we talk about resuscitation as well. I can talk more about resuscitation should you want me to. It's quite an emotive topic. It's one that we have to have legally now with patients and families, although it is still a medical decision as to whether we resuscitate a patient. Resuscitation refers to the moment that the heart stops. So what I mean by resuscitation is if somebody's heart suddenly stops, so if the heart dies, as a medical team, should we try and restart that heart with the artificial means that we have available to us? So by doing CPR, by chest compressions, calling an ambulance, using drugs to try and restart the heart, and electricity to try and restart the heart. So there are conversations that I have with patients, and as I said, I can talk more about that if you want it's a topic of conversation that I have very early on, and try and help patients and families realise that actually it's a medical decision, but it's important that patients and families understand why I'm making the decisions that I'm making. Ultimately, we're not very good at resuscitation in spite of what films and television programmes show us. 1 in 5 people whose heart stops in hospital will have it restarted successfully. That figure is about 5% of hearts that stop outside of hospital. And for cancer sufferers, if the heart stops, the chance of us successfully being able to restart it is probably less than about 1%. So we're not very good at it. And I would only put somebody through the trauma of a resuscitation if I felt it was likely to have a positive outcome. So that's a topic of conversation we get involved in. I also talk about preferred place of care. So we've talked about that. I've mentioned that earlier. So would somebody want to be cared for in a hospital setting? And if they did want to go to hospital, would they consider having treatment to support their breathing? And if they wanted that, would they want a tube into the mouth in ITU, or would they prefer not to have that if they become that unwell? Would they prefer to be cared for at home? Or, as I said, a hospice is also an alternative option, where some patients come in for symptom control for a couple of weeks, and then we aim to get them back home feeling better if possible, or with additional care or equipment in place. All of these conversations are documented in something called a Coordinate My Care record, which is what we're using increasingly across London. You may have heard of that. So Coordinate My Care record is a really slick piece of information, a health record, which is shared across hospitals in London and with GPs and with us as palliative care doctors in the community and hospices. And it's also shared with London Ambulance Service. And in that record is just the most important bits of information about our patients. So what's their diagnosis? What's their likely life expectancy? What medications are they on? And what do they want to happen if they were to fall ill at home? And that way, if somebody was to become poorly, very unwell, very suddenly, London Ambulance can see, if somebody calls 999, can see what the patient's wishes are, and they can attend the home and help make somebody more comfortable or settled. They can call us and get us involved to see what we think the best thing for our patient is. And we can make a plan together without always that knee-jerk response of having somebody sent to hospital if that's not what they want. Alternatively, we can document and know that patient absolutely wants to go to hospital, and that makes the ambulance service very clear on what they need to do. And then advanced directives, you may have heard of, is something that I broach. Not always, often patients have thought about this themselves, but basically an advanced directive is a documented decision that's witnessed and signed by a patient stipulating what treatment they wouldn't want. So, for example, patients can say that they absolutely wouldn't want to have their heart resuscitated if it was stopped, or they wouldn't want to have any artificial feeding if they had a stroke, or they wouldn't want to go to ITU, or they wouldn't want they wouldn't want artificial ventilation. So it gives patients the power, or people the power, to write down what they wouldn't want in a set of hypothetical scenarios. It's particularly relevant for people who might be in the early stages of dementia, and they know that they wouldn't want to be artificially fed or resuscitated, and also in neurological conditions which can go on for years. So motor neuron disease sufferers, for example, really struggle with their swallow, and previously we would artificially feed them quite early on in their illness, and if they can't communicate that decision with us and they don't want that, then at least there's some written information about what they wanted earlier on in their illness. An advanced directive cannot request treatment. It's only a refusal of treatment. And then power of attorney, again, you may have heard of. So I ask every one of my patients whether they have assigned a power of attorney. So a power of attorney can be for health. and welfare, or for financial decisions. So I'm really interested in whether if my patients have got a power of attorney in place for health and welfare. And what that means is that person, that patient, has assigned an attorney, so somebody, they've nominated somebody to make health decisions for them in the event that they become too unwell to do so themselves. Now, most people have a next of kin who can advocate for them in their best interest alongside a medical team. So often it doesn't make much of a difference to the care that we would give. And so it's not the most necessary thing for health and welfare if you've got a next of kin who you trust to know what your best decisions are. But actually, what it means is that that person would become you, essentially, in terms of your decision making, so that they have the power to disagree with the doctors, although still the doctor's decision is taken into consideration. So it's something that some people feel a layer of protection with, knowing that they've formally assigned somebody to make health decisions on their part, but it doesn't usually change management. And then other questions that I ask are about family. So I'm really interested in people's social setup. What's home like? And that's why home visits are really good. I can see the home setting. I can see what the stairs are like, the space that we have available to us if someone deteriorates and needs more equipment. I want to know who's involved, who I might need to support as well. So we have a family support team that I can refer loved ones to if they're having a difficult time. As well as the patient themselves might need some emotional support from that service too. We also have physiotherapists and occupational therapists who can help with equipment at home and in the hospice setting as well. And thinking about carers as well. So I want to know what our patients can do for themselves, what they need help with, and what I might be able to offload their carers, if they're family members, doing by putting care in place via an NHS care package. And then finally, I need to think about religious and spiritual needs of our patients. So where I work is quite a prominent Jewish community, but all sorts of different religious backgrounds, and that can be really important to some patients and families. So it's something that I always ask about. So the end of life, how do we know when the end of life is approaching? It's really hard to tell, but I tend to look and tell families and patients to look for the rate of change, and that's often easier in cancer sufferers when treatment's stopped, because treatment can just really muddy the water, so it's really hard to see the trajectory of someone's condition changing. But when it gets to a stage where there are no further treatment options, looking at the rate of change gives us an idea as to how that disease is evolving. So if somebody's condition's changing over months, I expect that the end of life is probably months away. If someone's condition's changing over weeks, I anticipate that the end of life is probably weeks away. And when somebody's condition's starting to change over a matter of days, then time is short and we're looking at days. Similarly, when someone's condition is changing over hours, we say hours. In terms of symptoms that we might see, so if somebody becomes more unwell with an illness that is likely to take their life, again, particularly cancer is slightly more predictable than things like dementia. But what we tend to see is that people become increasingly fatigued. So tiredness is a symptom that we look out for. It's quite a common symptom because often medications cause symptoms of side effects of fatigue as well. But in the context of everything else, it's something that we think about. So tiredness that's progressive, and then reducing mobility and an increasing care needs. They're probably good indicators that things are starting to change. Also reduced oral intake, so eating and drinking less is a sign that somebody's becoming more unwell. And I think the temptation is, as humans, is when somebody becomes more unwell and not able to eat, is to force feed them and think that actually if we can feed them, we'll fuel them up and we'll make them better. And actually we can cause harm doing that, because force feeding a body that just doesn't need or want food anymore can make people feel quite sick. So it's looking at that combination of symptoms really in the context of their illness. Towards the very end of life, people do get more tired and start to become less responsive. Sometimes the pattern of breathing will change, and sometimes people get a gurgly sound in their chest, just because normally when we're well we can swallow our saliva, but when we become less well we can't. At that stage, normally the person that we're looking after is too poorly to be aware of what's going on, and it's more family that we're trying to support at that stage. And we use medicines to manage any breathing problems, to manage any of this gurgly sound. We use painkillers to manage any pain that people might be experiencing, and sometimes if people are feeling sick, we use anti-sickness medicines as well. So they're probably the most common symptoms that we see as we get to the end of life, and we can manage all of those symptoms with a syringe pump, so a little machine that drives a syringe that's connected to a needle that goes into the surface of the skin, a very tiny butterfly needle, and that releases a small amount of whatever medication that patient might need into the body to help prevent symptoms and manage symptoms so that they're comfortable and peaceful. If somebody has been on painkillers, which often a lot of our patients have been on it as their illness has progressed, if they can't swallow anymore, then we would convert that to an injection via a pump. And sometimes our patients actually don't need a pump. Sometimes they become less aware and just gently sort of become more sleepy and pass away that way. So every patient's different, but we have a strategy for every symptom, so that we can keep people comfortable and peaceful and less aware perhaps of what's going on. Some patients ask for that, and so we can use medicines to help make them a bit more sleepy if we need to. But it really depends on that person, and that's why getting to know somebody early in their disease can be really helpful, because we can get to figure out what some of their symptoms are being driven by. Every physical symptom can be driven by the mind as well, so that's worth bearing in mind. I see a lot as a general practitioner actually that during periods of stress in our lives, we might not feel the classical symptoms of stress or worry, but we might feel those symptoms by physical symptoms, like abdominal pain is a common one, sometimes breathing difficulties or chest pains, headaches are quite common. So I think with all of my patients, in whatever setting I'm seeing them, I always think, how much of a hard time is their mind giving them, and do we need to work on that? Because we can throw lots of medicines at the various different symptoms, but if the problem is in the mind, then they're not gonna solve it. So yeah, so lots to think about. So ultimately, our aim is to ensure that the end of life isn't something to fear. We want to enable our patients to have a dignified and peaceful passing in an environment that supports their needs, and with the people around them that they want to be around them ideally. So that's sort of my run through of what I do. I'll stop talking now and see if anybody wants to ask any questions.
Thank you very much, Sarah. That was really interesting. If anyone does have any questions, please do drop them either into the chat or the Q&A, as Alice explained, at the bottom of your screen, and I'll read them out, but I won't read out any names, so you will stay anonymous. We've had a couple of questions coming in advance, so I'll just start with those. The first one is from somebody who was admitted to hospice a short while after their debulking surgery for ovarian cancer, before they started chemo. This was to get on top of some digestive symptoms, which they eventually did. However, the hospice were very keen to get me to agree to a DNR, so a do not resuscitate, a DNR in the event that I had a heart attack or stroke or some such. I felt I was being written off as having one foot in the grave already, in spite of a successful surgery and with chemo due to start. It made me feel very unsettled in that I had no confidence that I would be looked after as someone who still had some life to live, but that I would be treated as someone who was already near their end of life. It made me very wary of going near a hospice again. I can understand that a DNR would be appropriate if my life was failing due to end-stage cancer, but don't people who still have some life to live deserve to live an otherwise healthy life without worrying about not receiving appropriate and life-saving treatment?
Yeah, so this is about resuscitation. So it's a question that we're asked a lot, and I think that the problem with resuscitation discussions is that we just don't do them very well. And when I started off being a doctor 12 years ago, however, whenever that was, we never used to have the conversation with patients. We would actually just make a decision ourselves as the medical team, without speaking to patients or families, because we knew it wasn't a particularly nice conversation. But actually the Tracy case in 2011 led to a ruling that now we do need to talk about it with patients and families. And as I said, we're just not very good at resuscitation. So as somebody who's been to multiple resuscitation attempts throughout my career and only successfully restarted a handful of hearts, I feel really strongly that that resuscitating somebody, unless there's likely to be a positive outcome, I just wouldn't want to put somebody through it. And it's not writing anybody off. So I think it's important that we remember that resuscitation only refers to whether we try and restart a heart that's stopped. So if the heart dies, do we try and restart it? It is not anything to do with if somebody's deteriorating and then with sepsis or kidney failure or heart failure or a complication after surgery. It doesn't mean that we don't do everything possible to stop the heart from stopping. So we can give IV antibiotics and fluids, and we can involve ITU if we need to. What it means is if the body is so unwell that the heart stops, should we be restarting it? And as I said, the statistics just aren't very good. So 20% for a hospital cardiac arrest, the heart stop success rate, and about 5% in the community, and probably about less than 1% in cancer sufferers. And resuscitation involves pressing the rib cage repeatedly to massage the heart. So we often break ribs and puncture the lungs. We have to get urgent access into the veins to give medication, and then we often use electricity to try and restart the heart. If we are successful in restarting the heart, so if somebody is in that 5% success statistic, or less than 1% for a cancer sufferer, then the chances of us getting that person to hospital is pretty limited, and then into a hospital environment and accepted onto an intensive care unit where they're put on a life support machine is very likely that they'll survive that. And then if they do get put on a life support machine, the likelihood of coming off that machine without a degree of disability is also very slim. So it's trying, I guess when we have these discussions, it's trying to be clear that we are not writing anybody off. What we're trying to do is have an honest conversation about why we make the decisions that we do, and being honest about the fact that we're just not very good at resuscitation. And so medically, we feel it's not appropriate to put somebody through that potential trauma. But it does not mean that we wouldn't give all the care possible to stop the heart from stopping and helping that person live a very fulfilled life for however long they might have left. So I'm sorry that she felt bullied into having those discussions, and they're difficult discussions to have, but they are conversations that we have, and as I say, they're very emotive. And because of the legal history that we've had over recent years, I think doctors are more nervous about having them, and so you can end up having them again and again and again as a patient and a family member. And yes, they're not particularly pleasant conversations. So I can see the frustration there, but please don't feel like that team were ever writing you off. They're just trying to be honest with you and have open discussions about what they think is in your best interests in the context of your illness.
Thank you, Sarah. Another question is, and you've answered this a bit in your talk, but maybe you could go into a bit more detail. I'm frightened of the process of dying at the end. How will any pain or discomfort be controlled?
Yeah, so I think a lot of people are frightened about symptoms at the end of life, and that's completely understandable. But what we're here to do is try and make sure that we get rid of that fear to an extent. So pain is managed usually with whatever that person's been taking during their illness. So we often use morphine-based medications. What type of morphine-based medication depends on the person. And if they can't swallow, we can convert that to an injection form via a butterfly needle into the arm or the thigh, into the very surface layer of the fat. So it's very different to having a cannula in hospital, which goes into a vein a bit deeper. This is in the surface layer of the skin, and it's just connected to a pump that releases the injection version of that medication over a 24-hour period. And what I do every day is have a look at the medication charts to see how many extra doses of that injection medicine, whatever it might be, whether it's painkiller, whether it's a relaxant medicine, whether it's an anti-sickness medicine. I have a look at the drug charts with my team or with the district nurses in the community and say, okay, well, that person needed a few extra doses of whatever medicine. Let's incorporate that into the pump to try and prevent those symptoms from coming on in future. So it's having an ammo of medications available that we may or may not need. And when I go into patients' houses, one of the things that I introduced early is the concept of anticipatory medicines. So that's just in case medicines. So an injection for pain, an injection for nausea, an injection for anxiety and agitation, and an injection for the secretions, the breathing secretions, that the patients and their families can just put in a cupboard in the hope that they will never need them. But if they were to develop those symptoms, we have them there just in case, so that a nurse can come out and give those medicines to help settle somebody if they're in pain or distress, depending on what their symptoms are. But we try and be proactive and anticipate symptoms as we get to know our patients, so that we're not chasing them, we're trying to prevent them.
Thank you, Sarah. If anyone's got any questions, please do drop them into the Q&A or the chat box, and I'll be very happy to ask Sarah on your behalf. Sarah, if someone's listening to this and they're thinking that, you know, these are conversations around end of life care that they would like to have with their medical teams, and know that you know, that their wishes are recorded and things, and they're not yet linked in with the palliative care team, what's the best way for them to go about that and get those things organised and in place?
So the GP is probably the most accessible route. So I think first of all, having conversations with your family over a cup of tea and cake if you can, and again, trying to normalise it and not make it this weird thing that we've become so fearful of. And I think COVID gave us a really good opportunity to sit down with people actually and say, look, mum, I did it with some of my family members, what would you want if you were to develop a condition that needed, you know, XYZ treatment? And so COVID gave us almost an opening to have those conversations, because we didn't know what we were facing, and there was a risk that some of us might end up in hospital with this nasty bug. So I think it's about trying to express to your loved ones what you would like and talking it through with them. And then when you know, and make an appointment with your GP, they can access the Coordinate My Care record and they will create one for you. And if they think that specialist referral to have further conversations or to manage symptoms is appropriate, they can then refer to us. So as always, the GP is the best access point for that if you're not already linked into to our service.
Thank you, Sarah. This webinar will be recorded and will be available on our website, as Alice mentioned at the beginning, so people can always come back and look at this again. But are there any perhaps websites or books or things, because it's a lot of information, isn't it, to take it, and it's upsetting to think about, and so sometimes doing it in smaller chunks could be helpful. And are there any books or websites or other resources that you've found that people have found helpful on this, to think about these things?
Yeah, well, I think the Macmillan website's a really good resource and talks a lot about and talks nicely about death and dying and what to expect. Each hospice, when you get referred, will have their own website, and they'll often have pamphlets and little booklets. We give a booklet out every time we meet a patient where it talks a little bit about stuff like that. There is a brilliant book which I encourage family members and patients to read, called Being Mortal, by an American urologist actually, called Atul Gawande. He's a urologist, so his background is surgery, and he just learned so much, I think, about his outlook on life as a person and a doctor when his own father became unwell. And it really made him realize that, you know, we see death as a failure, but actually it's something that, as I said earlier, happens to us all. And actually we need to try and change our outlook towards it. And he goes through just lots of experiences that he's come across, as well as some of the research, but does it in a really nice way that makes you realize that, okay, so for example, when an oncologist stops treatment, that isn't the end of my life, or and actually there's still living to be done. And there's some data that looks at stopping treatment and how some patients live longer off treatment because the treatment can be harmful in certain cancers at certain stages of disease. So it just sort of twists the way that you look at it and makes you realize that death is part of living. And he does it really nicely. So he's now a famous author and is a speechwriter for Barack Obama. So I give that to people as gifts. So yeah, Being Mortal by Atul Gawande. But yeah, the Macmillan website is a useful resource as well. Oh, you put it on there. Thank you.
Thanks, Sarah. Yes, I've just dropped it into the chat, everyone. So there's the link there for the book that Sarah mentioned, but we can also include it in the follow-up email that we send round. And we've had a question come in. With ovarian cancer, I believe I will struggle to eat at the end as my bowel will block, etc. How is this managed?
So yeah, so a lot of patients with ovarian cancer worry about bowel obstruction, and I guess but ovarian cancer sufferers are at a higher risk of bowel obstruction than some other cancers. But when I think about the patients with ovarian cancer that I've cared for, most of them don't die of bowel obstruction issues. So first of all, don't assume that that's what's going to happen to you. I think if somebody does develop a blocked bowel, so what can happen is that cancer can deposit itself within the bowel wall, and that can shut off the bowel, and so stool and food can't move through it. And that means that you then feel very sick and can't eat without feeling very sick, and you can get pain just because your bowel is working against a blockage. So what we would do in that instance, if somebody was to develop that, and that can happen in lots of different cancers, colon cancer especially, just because of the location of that cancer. So when that does happen, what we want to do is try and rest the bowel. Sometimes I use steroids to try and calm down the swelling around where the blockage is. And then to rest the bowel, I sometimes set up a pump. So the pumps that we use at the end of life, we don't just use at the end of life. We can use that for symptom management, especially in bowel obstruction. So I can give painkillers via that pump whilst the bowel rests. I can give anti-sickness via that pump, again, whilst the bowel rests. And with steroids, anti-sickness, medicine to try and help the bowel move again, and painkillers, often we can get the bowel going again. If somebody's very early on in their disease or wants to go to hospital, then the surgeons will sometimes think about operating to cut out the blockage. And sometimes what the hospitals do is also artificially feed people via a tube into the nose, and to help them make sure they don't lose nutrition whilst they're unwell with a bowel blockage. But most patients don't die in that way. And I think patients with ovarian cancer or bowel obstruction will often die in a very similar way to the way that I described earlier. So often they will become more tired, they might get symptoms of sickness, they'll be eating and drinking less, and it's just that gentle deterioration that we would manage in the same way with medicines, depending on that person's symptoms.
Okay, thank you, Sarah. We don't have any more questions at the moment, but if there's anything else that anyone wants to ask that you're at all worried about, please do ask, because if it's concerning you, someone else will be concerned as well. And as I say, this is a recording, so it will be really helpful for people to when they listen to the recording as well. But if we don't have any more questions, then we'll start to finish. But Sarah, was there anything else that you wanted to add or come back to?
No. I mean, if anybody wants to ask me any questions, please, you have my email address. Please feel free to contact me, and I'll share my response as best as possible. I think everybody's journey is very different, and what I want to try and make people less fearful of whatever journey they might be on, and know that you're never ever alone, that we are here to walk alongside you and your families and make any symptoms and help any symptoms be managed, and be honest with you as well. I think sometimes part of having a cancer illness is the fear of the unknown, and if I don't know something, I'll be honest and say I don't know, and if I think something's bad, I'll say it's bad. It's about working with you as the boss in all of this to figure out our way together. So try use us early, and don't ever be afraid of the words palliative care or hospice, because that we can do a great deal to help people live.